able to see rainwater running down a window, but not being able to see through it, or steam rising from a mug, but not the mug itself. Imagine your daughter walking away from you and being able to see her ponytail moving from side to side, but not being able to see her face. These experiences are a daily reality for patient MC, a woman experiencing a form of blind sight known as the Riddick phenomenon. This phenomenon describes the capacity to perceive motion despite lacking the capacity to perceive static targets, true in a subset of patients with occipital lesions. It is a form of blind sight in which those with the condition correctly respond to stimuli in their blind visual fields at a rate much higher than chance. Following a severe respiratory attack, MC suffered extensive lesions to the occipital temporal cortex, right parietal cortex, and left ventral occipital temporal cortex, causing severe damage to visual areas. This can be seen in Image A in the empty areas indicated by the red arrows. However, her middle temporal motion complex, also known as MT+, and parts of the anterior occipital cortex were spared. This is in line with the commonly assumed structural explanation of the Riddick phenomenon, which poses that the sparing of alternative visual pathways, indicated by the gray boxes in Image B, can account for partially preserved motion perception despite damage to the primary visual pathway, indicated in Image B by the green boxes. Here, the MT+ is hypothesized to play a vital role. This video of patient MC demonstrates her ability to catch a ball thrown in her direction, despite not being able to fully perceive it as a normal person would experience. Patient MC's condition was tested in multiple sessions over several years. The initial psychophysical tests and fMRI imaging done demonstrated her spared motion perception and activation of her MT+ area. The psychophysical tests help researchers to understand and interpret what they saw in the fMRI scans of MC's brain. For the flickering checkerboard test, MC was presented with two sequential stimuli. One showed a checkerboard flickering to imitate motion, and the other showed a blank screen. MC was then told to decide which of the two showed the checkerboard. To test MC's direction discrimination, she was shown a screen with a vertical line or lines moving left to right, or a horizontal line or lines moving up or down. She was then asked to tell the direction these lines were moving. The random dot kinematograms is another test that, in addition to testing direction, also tests object expansion or contraction, as well as object rotation. She is not only able to detect motion, but also has the ability to discriminate between motion direction for complex stimuli such as grading bars. The activation of the MT+ area when doing these psychophysical tests suggests it is a robust and reliable finding. MC has reported improvements in her motion perception, including developing some experience of color. Increased activation in her fMRI scans across the years support this. However, there is still debate as to the accuracy of those findings due to different protocols in different labs. However, her experience cannot be refuted, and it isn't too far-fetched to think that as her MT+ pathway is still intact, the neuron connections in this pathway may strengthen as a result of increased use. She has been able to use her motion perception to master activities such as navigation and grasping, which has made everyday tasks much easier. Patient MC exemplifies the need for change within clinical practice that deals with patients of this kind. Blind sight patients tend to be told that visual recovery will not occur, but this is not exactly true. It took the clinician's full acknowledgement of her situation before patient MC could begin her road to recovery. After encouragement from her doctors, MC was able to adapt and improve her situation. The use of perceptual training, such as rocking in a rocking chair or horseback riding, improved not only her visual abilities, but also her confidence in these abilities. Finally, after much training and encouragement, MC was able to regain the ability to conduct everyday activities such as moving around her environment. This further exemplifies the need for improvements in clinical practice in order to provide all patients with the support and resources needed to adapt to living with blind sight. So why does MC's case matter? Well, to begin with, it illustrates statokinetic dissociation, the fact that motion perception does not necessitate static perception. Secondly, it shows that rich visual perception is possible despite extensive lesions to important visual areas. This richness includes not just basic motion detection, but also motion direction, and allows MC to interact meaningfully with her environment. Thirdly, it demonstrates that visual perception can improve following occipital injury through practice and the development of compensatory strategies. Finally, it supports the assumption that MT Plus plays a role in preserving motion perception and suggests that visual perception is not solely reliant on the primary visual pathway. The case of patient MC also demonstrates the need for change within clinical practice in terms of the treatment for patients with Riddick syndrome and other forms of blind sight. That's it for this presentation. Thanks for watching.